Hello and welcome to another Piper Pearl. Today's Pearl, we're going to be looking at early detection of breast cancer. Now this is deliberately called the early detection of breast cancer because there's been quite a significant number of changes over the years, probably the last 10 years realistically, and there's a lot of information out there on breast cancer screening, and sometimes it can be very, very difficult to filter through the actual evidence and different country standards. So today we're going to focus on Australian standards. So please note if you're listening in a different country, then the standards and recommendations may slightly differ, but the evidence and prevalence and everything else we talk about to do with breast cancer will still be pertinent. So as we go through today, we're going to talk about what's changed, what some of the complications are in finding information, and what the current recommendations are for early detection of breast cancer. So we'll start right at the start. We'll talk about what has changed. Now, depending on how much you've followed breast cancer, you may already be fully aware of this, but there's still a lot of conflicting information on the internet, which is people's primary source of information. And because it's the World Wide Web, it's very easy to find a lot of Cancer Council and breast cancer associations and national guidelines for breast cancer, which may not be national or even related to the area that you live or the place that you practice. So it just shows the importance of proper research and looking at recommendations from your country to see what's available in order to give the patients the best opportunity to early detect breast cancer. So some of the biggest confusion around breast cancer screening and early detection comes with the self-examination that used to be quite popular, in certain realms still is quite popular. And when you look up across the countries, they have recommendations ranging from different types of women that have to do it, when they should do it, and that sort of thing. So the common one that is recommended is that every female from the age of breast growth should do a self-examination every month. Now this is in direct contrast to two very large studies that were done in Russia and Shanghai. First one was done in Shanghai, which is the first formal evaluation, and that was in 2002. And that demonstrated no survival benefit or increase in identification of benign lesions, and often resulted in unnecessary biopsies. So the encouragement of self-examination didn't change anything to do with the survival rate or the positive detection of breast cancer, but did result in a huge amount of unnecessary biopsies. And this was similar findings in Russia, which was done in 2009. They had the same sort of outcomes, to that extent that the United States got involved, and they have a preventive service task force, and they released a guideline with a grade D recommendation. For those that don't know, that's very high recommendation against breast self-examination. This recommendation was cited around causing harm, as in doing self-breast examination was associated with causing harm with the procedure. It often resulted in frivolous imagery and way too many unnecessary biopsies, which ultimately resulted in a lot of psychological harm relating to false positives. So the biopsies will come back, and then after they went into surgery, it would end up being a false positive, causing psychological harm because the women would have part of their breasts taken out. And there was also cited that the actual feeling of guilt and the anxiety associated with needing to do very specific self-examinations regularly every month at the right time, then it became very stressful. So the whole thing was leaning towards self-breast examination not really being a thing. Now this met with huge resistance across the world, and it was abandoning mostly based on anecdotal evidence of high incidences of positive experience from patients and practitioners in this using of self-examination techniques in order to early detect breast cancer. and also the still quite high rates, which we'll talk about, of breast cancer. So the whole world was in a flux of what to do. They had pretty strong evidence, like strong evidence of harm and not much survival rate benefits or even detection benefits, but they also had the comfort and patient preference and practitioner preference and still quite high rates of breast. So we still need to be able to have something in order to find and early detect breast cancer. So that's when most countries came up with the recommendation of breast awareness over routine and ritualistic checking. So instead of having a calendar and apps and routine that you must do, now it's more about familiarity with the breast, familiarity with how it looks and how it feels. And that's what we'll be talking about today, because that is the same recommendations that the Cancer Council of Australia has also picked up, but with the added bonus of advanced screening. Now, to be fair, this is relatively new, so there's no strong evidence that this breast awareness is going to be the same as breast self-examination, whether it's going to be better or where it's going to be worse. But that is the recommendation that Australia has come up with. So that is what we will talk about today in more detail. So that's the state of the world, and that's where it's all come from. But let's spend a little bit of time talking about the cancer itself, its prevalence, its signs and symptoms, and what sort of things the patients can find to help with early detection. So risks associated with breast cancer are quite different to other cancers. The obvious one is obviously if you have a history of breast cancer, meaning you had breast cancer in one breast, you're unfortunately quite likely to have it in another. It's actually the leading metastatic cancer in women, which means it's often a primary source of cancer that leads to secondary cancers and spreading around the body, often due to its anatomy and close proximity to lymph glands within the axilla region, but it does metastasize a lot. So if you have a history of breast cancer in one side, then you are unfortunately likely to get it into the other. If they do biopsies and they see histological abnormalities, so if you've got fibroids, you've got cysts, you've got any abnormality growing within the breast, then you do have a higher risk of forming breast cancer. Family history is something to think about. First degree history of breast cancer has a threefold increase in risk, but in all the numbers, family history breast cancer only accounts for 5% of all the cases. Reproductive risk factors are quite scary and have been linked pretty markedly as well. And those risks include if the patient started their period before the age of 12, if they had a child after the age of 30. Now, morbidly, the child has to live. So they have to have what's known as a live birth after the age of 30 in order for this risk to be in place. If they don't have any children at all, then that actually increases their risk. And if they start menopause after the age of 55, it also comes with an increased risk for breast cancer. The other one that is quite close to home, especially in the Western world, is that exogenous hormonal use. So this is the case of progesterone and estrogen hormone replacement therapies, both premenopausal and postmenopausal as well, also comes with a marked increase in risks associated with breast cancer. So not a very nice list, and some of those lists will hit quite close to home with people that you know and maybe yourself if you're listening. So just be aware that whilst the risks exist, the sheer presence of any of these risks does not guarantee that you're going to get breast cancer or the patient's going to get breast cancer. When we have a closer look at epidemiology, like testicular cancer, its highest rate around the world is actually found in Western Europe. Must be something about Western Europe because a lot of the cancer rate seems to be higher there compared to others. Now, don't get me wrong, this is closely linked with Caucasians being greater risk as far as races go, but generally across the world, you'll have a 1 in 8 women will develop some form of invasive breast cancer. Okay, and that's up to the age of 85. In the early 2000s, there was a marked decrease in breast cancer correlation, and that was found to be directly related to an overall reduction in hormone replacement therapy being used. So they found that countries that had lower rates of hormone replacement therapy with patients had a direct correlation with lower cases of breast cancer development. Okay, so if you're in an area and it has a heightened increase of hormonal replacement therapies, then you'll generally find higher rates of breast cancer, which is something to keep in mind. Now, luckily, and good news, over the last 25 years and still going, the death rates have decreased, and that is mostly to do with the early detections that have been put in place. When we talk about age, it basically increases from 1.5 in 100,000 between the ages of 20 and 24, so it's quite rare to get it at the age of 20 and 24, all the way up to 421 in 100,000 at the age of 75 to 85. Okay, so 95% of all the cases occur in patients over 40, 75% of the cases are over 50, with a mean age of 61 to get breast cancer. So it is people later in their life that are mostly getting breast cancer. And that's not to say that people that are younger can't get it at all. You just have an increased probability the older you get. Signs and symptoms of breast cancer. Most of the time, especially when self-identification, like breast self-examination was in play, most of the symptoms were completely asymptomatic, resulting in most of the time when the lump got a little bit bigger, they were felt by accidents. And this often led to the push against routine and into more familiarity, because most of the times women were identifying lumps, it was by accident as opposed to actually conducting a breast self-check. So there you go. Pain is rare. Only 5% of patients actually have pain, but this is often overlooked as a sign of PMS or just general breast pain. When we start looking visually, you can have a huge amount of changes, and these changes are the ones that the cancer councils and other places recommend women look out for in different positions. So we change from lumps, changes in skins, unusual breast pain, size and shapes. They've created a image using lemons, which does help sort of denote different characteristics that you can find when looking for signs that could be breast cancer. So it changes from thick masses that you can see or feel, indentations, skin erosion, redness or heat, any fluid or any different sort of fluid that actually leaks from the nipples, dimpling, bumps, lumps, varicose veins, different size and shape, a condition known as peau d'orange, which basically means that the edema around the fine hair follicles make it look like orange peel, and on palpation there's a lump that feels round and almost like a lemon seed is what they say. So this is what women are encouraged to look and feel for without the specific routine of doing so anymore. Now, there is still recommendations that as the women are getting familiar with their breasts, they get familiar in different angles. So they have a look in the mirror standing straight, and then they place their hands above the head in order to put increased pressure on different parts of the breast. And then they also lie down, shifting the breast tissue mass, resulting in lumps sometimes being more visual, and using a mirror, handheld mirror, in order to have a look. That still exists in recommendations. Now, in the event, because we're clinicians, in the event a patient arrives and they're complaining of lumps in the breast, so they've gone through, they're just getting breast aware, and they find a lump. When they come to you complaining of a lump, there is no need for you to palpate the area yourself. You can talk the patient through different ways of palpating, understanding where the breast tissue is. It can go all the way up to the second rib, all the way down to the xiphoid process, and sometimes even in the axilla area and from the sternum itself. So palpating the entire region can be something you can instruct the patient to do and just teach them to do it like you would normal palpation. When they find the lump, get them to explain where it is, what the size it is, the shape, the feel, write all that down, and ask about all the other findings associated with what we just spoke about. Is there any shift? Is there any size changes, any leakiness, redness, skin irritation? Whatever it is, get those other symptoms. You can palpate the associated axilla lymph nodes because it is a very common sign if the actual mass is starting to metastasize. From there, you can refer with education. You can educate them on screening options, which I'll go through soon, and you can also, depending on their age, tell them that the likely step post-referral is often an ultrasound prior to biopsies, if that occurs. So things to also be aware for yourself or for your patients is what services are available through the Breast Cancer Council of Australia. So there's set up 600 free sites for women to get mammograms within Australia, and it's a matter of calling a number or going online and booking an appointment in an area that's close to you. So there's a big push, and there's a massive target for women between the ages of 50 and 74 to get this mammogram done. So that is a target audience that is actively campaigned for to get mammograms done, because that is the area, the age group that possesses the biggest risk when you break it down. Any female over the age of 40 can get it done for free. Okay, so if you're over the age of 40, all the way up to whatever age, doesn't matter at all, you can get it done for free. There just won't be actively encouraging or marketing to you if you're not within that 50 to 74. Not excluded, can still go, can book an appointment, and you can get a mammogram done for free, no problems at all. If you're under the age of 40, then the breast tissue is often too dense to be useful using a mammogram. That's mostly why they don't. I'm not saying they never do it, but they find that ultrasounds and other things are more useful with women under the age of 40. So if you have a patient that is under the age of 40 and they're concerned, they've got risk factors, they've found lumps, whatever it is, you can educate them that ultrasound can be done, can lead to biopsy, and obviously pathology, looking at the cellular tissue thereafter, and then same treatment regimes will go from there. Bottom line is they won't be ignored just because they're not in the age bracket of over 40. Mammograms are recommended every 2 years as a routine. Now, obviously, in the case of heightened risks, you'll get different recommendations, and patients are encouraged to follow those. But you can tell your patients that if they're in Australia, they want a mammogram, simply calling 13 20 50 or Googling it, they can book an appointment at their closest centre. So what are the take-home messages? Because things have changed, we have a huge array of different age women, some that have been doing these sorts of things routinely for many, many years and will know more about it than yourself if you're not part of that demographic. So realistically, you can tell them that they can keep doing what they're doing. If they're already doing those breast self-examinations that they learned years ago, and they do it monthly, they do it as part of routine, it gives them peace of mind, there's no harm in doing it. If it causes stress, if it causes worry, if they're worried about missing it, all the rest of it, then the encouragement of just getting familiar with their breasts is the current recommendation. So know what they look like, know what they feel like, and know how they change between standing, arms up, and lying, and that's it. That's the recommendations now. There's nothing wrong with them using the myriads of apps, the myriads of calendars, the handout, the pamphlets, all the devices in the showers, the help guides. There's no problems if they still choose to use those. It's just not pushed for any newcomers, if you will. If they are insistent on palpation, there's nothing wrong with them getting a good feel of what their breasts feel like. Just educate them that due to the heightened prevalence of PMS, premenstrual syndrome, associated with tender breast tissue and finding of masses, if they're premenopausal, then it is best to do it 4 days post menstruation. Okay, so 4 days post menstruation, the signs of PMS should have dissipated, and therefore they're more likely to find masses that are associated with non-menstrual growths. From there, there's also nothing wrong if they have trouble remembering, have trouble seeing their breast, then they can always ask for help if they have a partner. Okay, there's nothing wrong with involving a second person in the checks. Just encourage them to get familiar with the size, the shape, and look and the feel of their breast tissue. So that brings us to the end of early detection of breast cancer. It is a very important topic to talk about. It's a very important topic to discuss with your female patients. Let them know of the associated risks, especially as your patients get older or are basically within that demographic that poses a slightly increased risk. Okay, we are moving into a time period where women are choosing not to have children. Hormone replacement therapies are starting to go on the increase for a myriad of reasons, so the risk factors are still there. Providing education to patients and providing them the assurance of what is most likely and what in the past has been the most probable way of finding and detecting true breast cancer can give patient peace of mind that simple awareness can be useful and beneficial in the early detection of breast cancer. But until next time, take care.